Assalamu alaikum. Welcome everyone on board. Um, Today we will be just revising some of the concepts which are needed with reference to neuroanesthesia. So, as you know, that I am usually doing giving you a concept, okay? Because everything is written in the books, and when we have reached up till the level of training and appearing in the exam, everyone knows about it. And the good thing about anesthesia is that anesthesia has very little anesthesia, and anesthesia is everything which is not anesthesia. Okay, so you should be knowing everything around and around the word anesthesia. Okay, so if we just consider this topic of neuro anesthesia, uh, usually uh, what should be your goals, or what should be the targets for you to know? Like any other subject, it should be starting from the physiology, okay? Because all the pathologies which will be occurring, usually they will be revolving out the cerebral physiology and the basically the ICP, okay? So whether it is trauma, whether it is any like intracranial bleeding, okay? Or whether it is some tumor, um, okay, or any bleeding. So trauma, bleeding, tumor, everything will be revolving around the ICP. And the concept of ICP is with reference to the physiology. Okay. The physiology is that usually the you should be knowing, having a good concept about the neurophysiology and the structures inside. There is some brain tissue, there is some vasculatures, there is some CSF, okay. And then with reference to the function, like what are the what is the basic system, the sensory system, okay, and the motor system and the autonomic nervous system. So usually these three things, and the fourth thing, which are actually somehow part of it, but uh, you can consider it as separately, is cranial nerves, okay, and last but not the least is the higher mental function. Okay, so higher mental function in the form of the conscious level and understanding and everything. And so, whenever you are either evaluating a patient or you are thinking to learn about neuro anesthesia, you should be knowing these basic steps. Okay, because the same thing will be that what is the, like if you just take an example of sensory or motor or autonomic, there will be certain things which will be changed if you are dealing a patient coming for any neuro surgery or any neurological intervention. Okay, because maybe it will be and another aspect will be that either you are working as a like ICU doctor to deal with a neuro patient. This will be one category. Other category will be with reference to emergency in trauma, with reference to managing the airway or transferring the patient to other facility. This will be another aspect of you, or another aspect will be now that patient needs some emergency surgery. This will be usually with reference to extradural hematoma or subarachnoid hemorrhage or things like that, in which you need to have some immediate procedure to be done, or it will be an elective surgery with reference to a tumor, or there may be some other things. But usually the elective surgeries will be revolving around either tumor or a management of epilepsy by some stereotactic surgeries or things like that, or these things will be done in OR, say, okay. And there will be another part which is actually there, you will be dealing with interventions, okay, endovascular interventions. So interventional neuroradiology is, you can say, a new domain, relatively new, not new, but relatively newer domain. And because not all anesthetists are familiar, or not all anesthetists are doing this intervention in neuroradiology anesthesia care. So this will be asked in the exams again and again. Okay. So whenever you are preparing for any exam where you are supposed to be asked about neuroanesthesia, you should be knowing these aspects. So I'm just giving you a bird eye view. Okay. So now we will just try to explore further. I'm just trying to give you an concept that what should be you should be knowing and how you should be approaching it. Okay. So with reference to, for example, ICU, because I'm just trying to build up a net in which you, with the points, we are exploring our discussion again more and more. Okay. So with reference to ICU, for example, if I say that usually the things will be, as I mentioned in my initial words, that ICP will be the thing which you should be considering at all the time. Okay. So there will be certain factors which you should be considering whenever you are dealing with the any patient you where you want to maintain the ICP. Because why ICP will be important? That either it is in a trauma in which there is a primary or initial brain injury, and there will be secondary brain injury. So your goal will be to prevent the secondary brain injury. Okay. So secondary brain injury will be exaggerated if you are not able to maintain the cerebral perfusion pressure. Okay. And there is a relationship between cerebral blood flow, cerebral metabolic rate, okay, and ICP. So all these things are interrelated. And the factors which are very crucial are the most important is CO2, O2, O2, and this temperature, viscosity, okay, and anesthesia medications. Anesthesia medications, like generally, as a general principle, usually the inhalationals will be increasing the ICP and cerebral blood flow. Okay. And the IV agents will be usually decreasing ICP, exception. There will be certain medications, like, for example, ketamine. If you are using in a slightly higher dose, it will be increasing. Okay. But when you are trying to make a concept, you should be focusing on all these aspects. All these aspects you should be considering. Okay. So now we will be just trying to go further. With reference to ICP, what you should be knowing that what are the factors which will increase the ICP, how to monitor ICP, how to measure ICP, and there are certain ICP waveforms. Okay. This is also with reference to the EEG and relationship with the waves. Okay, you should be knowing in some exams. You may be asked about these details of Lundberg waves, and there are certain, I don't recall all of them. We will try to just have a look on it. So ICP, and ICP, and cerebral perfusion pressure. So cerebral perfusion pressure, the factor which will be important in cerebral perfusion pressure is ICP, CVP, and the mean arterial pressure. Okay. So mean arterial pressure is in definitely in your hand. Okay. And you have to maintain mean arterial pressure, because otherwise cerebral perfusion pressure will not be maintained. Okay. Because ICP, you can decrease the ICP by somehow, but usually the thing which is will be a major determinant will be the mean arterial pressure. If you are not able to maintain the mean arterial pressure, cerebral perfusion pressure will not be maintained. So this is one of the key factor you should be considering whenever you are dealing any patient having some neurological injury, or even if you are doing a surgery. For example, you are for say you are doing elective brain surgery, for example, a craniotomy, whether it is posterior cranial fossa surgery or any neurosurgery in which so in that cases cerebral perfusion pressure is, because if you are not able to maintain the cerebral perfusion pressure, there may be ischemia. Okay. So that will be the next step, will be that how you can have a guess of how good your cerebral perfusion is. With reference to mean artery pressure, a very important fact you should not never forget is that you should be zeroing the arterial transducer at the level of the external auditory meatus rather than and the usual level of heart. Okay, because the head side usually indifferently will be a little raised. Okay, and it will just give you a rough idea about the cerebral perfusion pressure. Yes, of course, there are certain other advanced monitoring equipments which you are doing, and the topic is actually neurophysiology monitoring. Okay, neurophysiology monitor, and it is not only with the EEG, they are doing the evoke potentials. Okay, and they are also, can you just mute yourself, please? So EEG, evoke potentials, and processed EEGs in the form of BIS or entropy. This is not only for awareness, this is also for, actually indirectly you are just judging the cerebral activity. It is just a rough idea about it. And some more ways is like mixed jugular venous bulb oxygen. Okay, and there are certain, now I don't have too much knowledge how they are working, but there is one O3 monitor by this Massimo. This is one of the monitor which they are using it for like cerebral function monitors, okay, you can say. And there is one more. Inna lillahi wa inna ilaihi raji'un. I forgot the name. If I just recall the name again, I will tell you. If any one of you know that the name of that monitor, you can just write in the chat box, and you can just remind me. It just slipped out of my mind. So these are the modern monitors which they place on the forehead, and it is just giving one of the basic principle is that global versus focal ischemia. Majority of the factors which we are doing it are actually telling the global ischemia, not the focal ischemia, which is more important. Okay, because when they are doing any specific surgery in the brain, the thing which is more important is the focal oxygenation rather than global oxygenation. Okay, so this is with reference to neuro monitoring. Okay. Mm, yes, the name of that monitor is SedLine. SedLine. Okay. You can just Google about this O3 monitor and SedLine. Okay. And the other is jugular venous bulb and global versus focal with reference to EEG, evoke potentials, BIS, entropy, and mean arterial pressure. So this is with reference because these are the common things. I'm just telling you the things which will be used whatever wherever you are, whether you are doing a posterior fossa surgery, whether you are doing any surgery in any position, the monitoring and the factors which are important for you are the same. Like you have to maintain the CO2, you have to maintain the oxygenation, you have to maintain the viscosity, you have to maintain the temperature. Okay, because if temperature will rise, there will be increased blood flow, metabolic rate will increase, and it will hamper the cerebral oxygenation. If you are increasing the CO2, it is directly affecting the cerebral blood flow. If you are having significant hypoxia, less than 60 millimeter of mercury, there will be significant rise in ICP. Okay, and it will decrease the cerebral perfusion pressure. So similarly, viscosity, you don't need to increase the hemoglobin to too high levels, which will decrease the movement of the blood. Okay, so this is with reference to the fluid dynamics principles which are there, that viscosity will decrease the flow. Okay, so these are the basic principles. The same principle will apply whether you are dealing a patient with subarachnoid hemorrhage, or you are dealing any brain tumor surgery or any trauma. Okay, so same principles will be there. There is no difference about it. And then there are certain concepts which should be knowing. Is one of them is cerebral steel. Okay, they can ask you about it, or they can ask about this Robin Hood phenomena. Okay, then another important concept you should be knowing is Cushing's. All know about it. You should be knowing that what is the factors which can cause, like Cushing's response is a sign that there is raised ICP, there is hypertension, and there is bradycardia. Of course, the third component will not be very evident if you are having a patient under anesthesia. Okay, so any question up till now? Are you with me? I'm sorry. Okay, so we will continue because individually we can go in individual topics, but this I'm just giving you an overview that what you should be dealing or what are required when you are uh, luxury perfume. Very good. Luxury perfume is another concept that you have more fluid, more blood and less requirement. Sorry, luxury perfume. Then what is required? Okay, thanks for reminding me. So this is the so now up till now, just think about it that now if you are giving anesthesia, okay, so the challenges or the things which will be in your mind all the time, ICP, 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 and ICP. Whatever you are doing, the thing, the concept will be in your mind. So there will be certain challenges that you will have to avoid secondary brain injury. You have to avoid the factors which will be raising the ICP. And at the same time, if surgeon is saying that I have a tight brain, what to do? So this is something which you should be having very good concept that you will be increasing the FiO2, you will be hyperventilating. Okay. If you are using any inhalational agent, you can shift it to TIVA. Okay. This is another thing. Then other maneuvers you can diurese. Okay. So diurese by either furosemide or mannitol. Okay. So you should be knowing what are the problems, how much is the dose. They can ask you what is the mechanism, how it is. It is also cerebral protection, not only for decreasing the ICP, it has some effect on the cerebral protection as well. So similarly, FiO2, hyperventilation, TIVA, these are the things you should be knowing. Then, if any tight tubing, sorry, tight draping on the neck, if you have put the tighten the tube very tightly, this will have a more cerebral blood flow and less. Yes, yes, this is it. Less requirement and more availability. Tight bandage. Okay, so tight bandage is one of them. Okay, and if there is any pressure in abdomen, can it increase the ICP? Yes. Okay. If you are using inhalational agents with the people say that you can use up to 1 mag. Actually, if this is a practical concept, I'm telling you that theoretically less than 1 mag is okay, but practically, believe me, if you have a chance of a facility of using TIVA, don't use in that time. At least you can use it at the end of the surgery, but till the time they are removing a mass or they are in a critical step, don't use it. Practically, there is no need for using inhalational agent if you have the facility of TIVA. Okay, TIVA with because TIVA is a separate topic, but I'm just telling you that if you have the facility of TIVA, you can easily bypass inhalational agents. Okay, because nitrous oxide does not affect too much. So maybe it's again a question mark, because there are two group of people. Some people don't like nitrous oxide as well, but actually this is again I'm saying that maybe in some books you will find that it can increase ICP or it can increase, but nitrous oxide actually is not as harmful as inhalational agents. Okay, there will be certain things which you have to think about it. So I'm just trying to give you a theoretical academic point of view as well as some practical tips. So this is a challenge which you can have when you are dealing a patient with for any neurosurgery. Another thing, another thing which you have to be aware about it is the air embolism. It is gone. Air embolism. Okay, air embolism. So for air embolism, there are certain questions how to detect about it. It is end-tidal CO2 loss of end-tidal nitrogen increase, okay, or sudden fall in cardiac output, sudden hemodynamic collapse. Okay, so immediately you should be knowing that drill. You will inform the surgeon. You will immediately do the head side down. And for the prevention, you will always tell that with the one of the CVP port, you will attach the 50 cc syringe for flushing or as well as in aspirating. Okay, so this will be the drill for air embolism. So because any surgery above the level of heart, actually theoretically there can be air embolism, but it is more so in posterior cranial fossa surgery or any neck surgery in which the big vasculature is open, but it can occur in any surgery. So you should be knowing about it, how much air it is needed, how fast it should going, okay, and how to detect it. And there is also end-tidal nitrogen and transesophageal echo. Of course, nobody use it practically, okay, but theoretically they can. You should be knowing that the most sensitive one is the T, and the in initial maybe only end-tidal CO2. So these questions can come even in MCQs exam in a different way, and you should have a concept how it will and what will you do. So air embolism, venous air embolism is one of the topic which is part and parcel of it. And what else? So with reference to posterior fossa surgery, now I will try to give you some. I have told a number of things which are common. With reference to posterior fossa surgery, high chances of air embolism as well as bleeding. Okay, and vital centers are there. So vital centers, there may be more chances of postoperative apnea or postoperative ventilatory support or things like that, more so in posterior fossa surgery. Then another important aspect, a buzzword you should be knowing is the prone position. Okay, so all the concerns which are there in prone, any surgery in prone position, you should be knowing with reference to like any position when you are describing any position, as I mentioned yesterday as well, that creation of the position, effects of that position, and reversal of the position. So all three things you should be knowing. There may be engorgement of the face, there may be engorgement of the eyes, there may be ischemic optic neuropathy, okay, which is not only related to pressure, it is only because eyeball will be hanging. Okay. So if the patient already had some baseline retinopathy, it will be exaggerated. And maybe it is resulting in blindness at the end of the surgery. So this is very important. Okay. Because a number of surgeries in prone position, actually, they are also asking for tranexamic acid. So by the way, tranexamic acid itself can cause thrombosis. And these are very tiny vasculature. Okay. So you should be very careful. So that's why it's better to give, if you need to give tranexamic acid, it is better. It is better to give an infusion rather than a big bolus. Okay. So ischemic optic neuropathy is an important factor. You should be thinking about it. You can read in detail about each and every topic. I'm just giving you a hint, the main buzzword points which you should not forget. Okay, and then uh, breast tissue, genitalia in males, breast tissue in females, and then very important is abdomen. Abdomen, there are actually special tables with a hole in the center for the abdomen. They, unfortunately, these tables are not available everywhere. Okay. Other than they plates, a lot of pillows, a lot of jellies. Okay. So you have to be very careful about it, that the neck should be fixed. And very important is the flipping of the patient. Whenever you are flipping the patient, it's very important to keep the patient in an alignment. In a number of centers, I have seen that usually even in the spine surgery, usually they put the pin, okay, and they fix the head. So there actually the advantage is that the head is free and there is no direct pressure on the head. Yes, pinning is itself is a very painful procedure. Okay. And whenever you are anesthetizing the patient, this will be the time when the surgery has not started and you have decreased the depth of anesthesia to maintain the blood pressure. Suddenly, when they are doing the pinning, you should you should tell the surgeon to remind you when they are about to do the pinning, number one. And they actually, in the theoretically, they can also give a scalp block to at the place where they are putting the pin. If they anesthetize the skin and subcutaneous tissue, some of the pain will be reduced. Of course, when they are touching the bone and osteotome, still there will be pain because maybe it will not be fully covered by the scalp block. Okay. But you can use mention and or you need to give some extra anesthesia at that time. Okay. So pinning, eye, genitalias, prone position. These are the things which should be in your mind whenever you are dealing such patient. Again, I'm just in enhancing the discussion. Any neurosurgery, that as I mentioned, that you should be knowing at the sensory system, motor system, cranial nerves, higher mental function, any neurological deficit which is there preoperatively should be clearly mentioned. Okay, this is one thing, because if it is occurring at the end of the surgery, so it will be put on you that you are the one who by like which created the problem. So that's why it's very important to document not only the radiological findings, okay, because indifferently there will be some radiological findings, there will be some clinical findings. Okay, so so you should be knowing how to document it and how to put the risk. A number of time post-operatively the patient will be kept intubated and ventilated, but if you it depends on the manipulation. And usually surgeons these days I have seen that if they, because now yes, one more thing which I recalled, so I'm telling you another concept which I have not seen in many of the setup, but we should be knowing about it, is navigation. I don't know very nicely how to do it, but there is a special scanning system by they which they do the navigation to start with, and this navigation will tell exactly mark the angles at which they are supposed to enter the brain. Okay, depth, angle, how they should. This is not related to you, but this is something which you should be knowing about it. So they do the navigation before they start. And neurophysiology, they will be putting the pins all over the body. Okay, the not these are electrodes by which they are stimulating the sensory and motor system. Okay, the evoke potential, the motor evoke potential, the sensory evoke potentials, they are measuring the EEG. Okay, they are observing everything, because any change which will be occurring, they have to immediately inform the surgeon. This is not only for neurosurgery, this is also true for spine surgery. Okay, any spine procedure, in majority of setups they are doing a neuro monitoring with reference to. So in whenever there is a neuro monitoring, you don't have to use a muscle relaxant, you don't have to use the factors which can affect the reading. Another important concept in this with this reference is they need a balanced anesthesia and that's why the concept of TCI is there, target control infusion. And they because it will maintain the drug levels in a better way as compared to the normal Tiva pump. Okay, but bolus are not good. Okay, if suddenly patient moves or patient depth of anesthesia decrease and you give a bolus, bolus is not good, because bolus can interrupt with the uh, findings of the neurophysiology. Okay, so usually as a principle, it is better to maintain in a steady state and maintain it with a like constant level. Another, yes, with reference to Tiva, another important point you should be knowing, that it is better to attach Tiva on the foot. Okay, because sometimes there are incidents that you have attached it to CVP, it's not going nicely, or any line which is away from you, because access will not be there in the upper part of the body. So it is better, not 100% mandatory, but it is better to give Tiva knee in the foot, so that you can monitor it in a nice way and it will be nearer to you, and you will have more access at that place. Okay, so this is another important point with which you should be knowing. Okay, then then certain I'm just changing the subject for a while. Usually with reference to trauma I'm going for a while. So with reference to trauma, important thing with reference, even it is neuro anesthesia, but any patient with disturbed neurological status with either AVPU scale or GCS scale, the next step will be the patient might need to be intubated. Okay, so they can ask you what are the indications, or you will find in all the books the reason how and you should be. But this is a question you should be prepared. Like these are then another question will be CT scan. When to do CT scan? Okay, you will find a chart, any drop and GCS. There are certain things. I can show you the article, but I'm just telling you that you should be definitely, you should be knowing what, because in the exam they will ask you to tell 1, 2, 3, 4 reasons of doing CT scan, reasons of intubation. And with reference to intubation, what you should be knowing is just a second, please. The how to manage the airway, how what care you need with reference to airway management in a trauma patient with possible neurological involvement. So the things which you should never forget is MILS, manual inline stabilization, because you have to consider to have a spine injury unless until ruled out either by nexus criteria or cervical, sorry, Canadian C spine rule. So you can just Google it and you will find a certain criterias that unless that criteria is fulfilled, you will consider to have a neck injury, cervical injury. Then you will do the mills. You will try not to extend the neck, okay, and you can use glidoscope, okay, glidoscope or awake fiber optic according to the situation. Not in every patient you can do awake fiber optic, okay. So glidoscope will be a good option. You can tell that these are the things we should and they can in the exam, and then this mills, they can ask you in the TOEIC exam as well, the OSCE exam, how to perform the manual inline stabilization. How many people are needed? One will be holding the neck, one will be holding the head, okay, and how you can put two sandbags on the either side of the neck so that the neck is fixed, and you are using the glidoscope, you are having the cervical collar, which is there. Try not to remove it, try to intubate with it. Glidoscope will help. That's what I'm telling you. These are practical things, but you should be knowing. So the reasons for CT scan, the intubation indications, when to intubate, at what GCS level, what conscious need to be done. These are the questions which they can ask you in any exam. These are, like, you can say paper is out. So you should be knowing that these things with reference to trauma, with reference to neuroanesthesia, you should be knowing. Then another important, actually, this is a separate topic, but transferring a neurosurgical patient. Okay, a neuro patient. This is another important topic you should be knowing. So there are whole of the discussions done, what requirement you have. You should have a special equipment. You should proper handover. You should be knowing all the emergency medication should be with you. The double oxygen supply that for the expected time of traveling, whether you are traveling from emergency to OR, whether you are transferring from emergency to CT scan, or whether you are transferring from one hospital to other hospital via ambulance or air ambulance even. They can ask you this question. Majority of the things are the common thing. There are certain differences which will be there in extra. So there are so many articles on transferring a critical ill patient. This is also part of your goals to be achieved when you are preparing neuroanesthesia. Okay. Okay. So what else? We have discussed about ICP. We have discussed about general management. We have discussed about the rest of the things are actually are the common, the craniotomy stuff, whatever is there. Usually these are the benign tumors. If you are talking about tumors, okay. So usually, but they will be involving certain things systems. Another exception to this one will be the transfinital approach of pituitary surgery. Majority of the concerns will be the same. CSF rhinorrhea can occur post-operatively. The concept of the rest of the things will be the same, believe me. The neuroanesthesia will be the same. The ICP and other factors will always remain the same. Only the approach will be changed, and like certain points will be different. So now I'm going towards some points with reference to interventional neuroradiology and with reference to some like subarachnoid hemorrhage. Okay, subarachnoid hemorrhage, and like extradural hematoma, if it is occurring, it's an emergency. Okay, because if you are not able to relieve the hematoma, there will be midline shift and there will be neurological damage. Like you can say the same concept, that if you are not really releasing it urgently, there will be chances of secondary brain injury, because whatever injury, initial brain injury has been done, The secondary brain injury will be prevented if you are able to drain it. Okay, with reference to subarachnoid hemorrhage, again, they can ask you about the cerebral aneurysms, what are the factors, what are the types, and what are the risk factors for cerebral aneurysm. And then there are two categories. One is that atomic bomb is there, which is not burst, and one that blast has already occurred. So one is the ruptured aneurysm, and the other is still which is not ruptured. So there are certain difference in the approach that if it is ruptured, now there may be chances of cerebral vasospasm. Okay. So you have to prevent the spasm. So the ICP factors will always be the same, almost be the same. Only there was a traditional triple H therapy from which one of the H is not already gone. So they say that it should not be hypervolemia, it should be normovolemia. Okay. And again, another thing is that the blood pressure should not be allowed to be go down. Again, because these are a number of times these are misnomers. So hemodilution is yes, hemodilution, as we mentioned, that the viscosity should not be more. Okay. And hypervolemia is never good. So you can say that you will maintain the blood pressure, you will maintain the volume. It should not be hypovolemia. It should not, like you can say hemodilution and hypervolemia is almost the same thing, because hemodilution can be done with normovolemia and hemodilution can be done with hypervolemia. So but in the exam, they practically, I have never seen it happening, but in the exam, because it is written, so you can tell that traditionally it was called as triple H therapy. But with the modern gadgets, modern availability of neuromonitoring, actually there is no need to full the body. You can achieve the goals, you can set the neuromonitoring, and then if anything is happening or any signs are coming, that then you can do it. But usually this is the triple H therapy that you should be knowing. And there are very terrible Hunton and Hess classification, which I don't remember, but you should be knowing about it. And there is another Glasgow some scale for CT scan. So you should be knowing these classification with reference to subarachnoid hemorrhage, triple H therapy, and all the factors to prevent and treat. For the treatment, it is nifedipine, which is commonly being used for, sorry, nimodipine, not nifedipine, nimodipine, nimotop. Nimodipine, they use for treating cerebral vasospasm in addition to all other factors. Okay. If it is not ruptured, okay, even if it is ruptured, sometime they are taking the patient to neuroradiology. Okay. So neurointerventional radiology, usually in majority of time, you are giving monitored anesthesia care. They are not, you are not giving anything. But at that time, any complication can occur. Arrhythmias can occur, neurological insult can occur, bleeding can occur, aneurysm can rupture while coiling or while doing any intervention. Any complication can occur. Okay. So actually, interventional neuroradiology is one of the domain of anesthesia, which is actually very difficult. It's very tricky. It's like a sweet in Pakistan, jalebi. It's simple or tricky like a sweet which is like this. So it looks very simple, but it is very complicated. So you have to be ready for any complication, any hemodynamic instability, any arrhythmias, and so neuro intervention, neuro, of course, it will be depending on different scenario, different patients, because it's for so many procedures these days. Carotid stenting is being done. There are so many procedures which are being done in interventional neuroradiology, and you will find a lot of articles in the Google Drive link, which I share with all of you. So you can have a look on it. Basic principles are the same, but MAC is one of them. Anticipation of complications is one of them. Okay. Sometimes because they need a steady patient. If the patient is moving, they cannot do the procedure. Okay. So usually people think that they will be cutting something in the head, but here, no, they are entering from the peripheral artery or peripheral vein. Okay. So interventional neuroradiology is something which you should be knowing. The basic principle will remain the same. If you have any doubt, you will do the, in addition to all the monitoring, you can have arterial line, okay? And you should be ready for any disaster. And also the concerns of ambulatory
So,
anesthesia will be there. All the concerns of out of OR, remote area anesthesia will be there. So whenever if they are, if you are asked about interventional neuroradiology, you will be telling that all the concerns in any neurosurgical or neurological patient will be there. And in addition to that, concerns with reference to epileptic care, concerns with reference to like monitored anesthesia care. Okay, so these things will be there, should be in your mind when you are dealing such case. Okay. So interventional neuroradiology. So please just tell me anything which I have missed, because I have just given you a bird eye concept about neuroanesthesia. Any questions? Because it's prayer time here, so I might need to leave after few minutes. So any questions or any comments? Maybe we can have another session on neuro anesthesia, because there are certain, like one topic is awake craniotomy. Okay, awake craniotomy is one of the topic. Okay, awake craniotomy is one of the topic which they can ask you. Okay, and awake craniotomy is done for like what you say. I don't have very good concept about. I have never done awake craniotomy in my career. Okay. Um, but usually they are doing it for epilepsy, they are doing it for eloquent speaking area surgery. They want to keep communication. So there are different techniques about it. You sleep the patient, and in between you make it awake, and then you again sleep awake sleep technique, or you keep the patient just quiet and calm with dexmedetomidine, and they are doing the surgery. They are doing the scalp block. Okay, as I mentioned to you, and they are doing the monitoring, and anything happens, they are, but and at any point of time you should be ready for airway management, because at any time a point of time airway can collapse. Again, the rest of the common things are the same. Common things will always remain the same, whatever surgery you are doing. Just let me have a look on anything which I have missed. uh,
Just Hashim, if you don't mind,
yes, sure, please.
regarding zeroing of the transducer, I will make zeroing after fixing the position. I
Okay.
mean, parallel to external radiometers, or zeroing mean making the pressure reading room pressure. Then accordingly, the transducer I will put up parallel to external radiometers or down. It will make the reading. The point
um,
of the
no, I will tell you. Actually, usually whenever we start the monitoring of arterial blood pressure, okay, just after attaching, we open and we zero the line. Okay, so when we are making it zero, at that time the transducer should be at the level of the external auditory meatus. You have to make it zero at that. Okay.
You mean after fixing the position, and the transducer will be parallel to the external audiotromutus, or the same
Yes,
line.
you make it zero it, and then you will monitor from there. Okay.
Yes. Thank you.
sir,
So
can you
tight
tell
brain.
us?
Yes.
Can you tell us the indications of CT scan?
No, because I don't have time to tell the indications. It's available all written in the books, Dr. Humera. It's written in the articles. I have just tried to give you a concept. Okay. I cannot recall the indications of a CT scan. It's all written. I can show you the Google Drive link. You can just open it. Okay. And you will find all the indications written. Let me show you. Any other questions, please?
Last one. Monitoring regarding the central venous line. Is it routinely we should do, or it depends on the situation?
Okay, actually, in any other surgery, because many years ago, CVP was used with reference to fluid status. Okay, so now it's neither it is indicated only with reference to fluid status, or it's not used for to give medications. Now, only indication in this scenario is that with reference to air embolism. Okay. So another thing,
Thank you.
if you are taking the patient in supine position, maybe you can say that in if it anything occur, you can do at that time. But if you are doing in a prone position, unfortunately, no. Okay.
Thank you.
So Dr. Humera, for you can see the chart. Okay. Because it was not possible for me. I have tried to give you like you can say 360-degree. That's why I use this word chatterbox. Okay, so it's like a chatterbox because I am not teaching a topic with a presentation. I'm just trying to give you an idea what can be needed, what can be required in neuroanesthesia. Okay, so majority of things are the same. As I you can see that I have, like, you will find, because there are certain other topics, craniopharyngiomas, resection, or cranioplasties. Okay, or but I have, you see, craniocyte, you can find there's neuroanesthesia cannot be taught in one sitting. I have just tried to give you, you can say, a bird eye view. Okay, so with reference to vascular problems, with reference to tumor, with reference to trauma, what monitorings are problem, inhalational agents, IV agents, muscle relaxant, analgesia. Analgesia we did not discuss too much, but actually there are certain steps where extra analgesia will be required, especially when they are doing the pinning and they are playing with the dura. After that, when they open the dura, actually the requirement of anesthesia will not be that much. Okay, our brain to study these topics. Yes, thank you, Dr. Nita. I need some comments from the people who are in uh, unavoidable romance with the Morgan. Okay, especially Morgan. So a few words, if anyone want, because I have to leave. I'm short of time, unfortunately. But remember one thing: all of us, all of us know we are studying. That's why from where I started. This is an article on neuro interventional neuroradiology. You can have a look. Okay, and if any question which I have missed, you all are welcome. The thing is that, my dear, all of you, remember one thing: if you have the concept, if you understand what are the things which can be required in certain topics, you can you can prepare. If you don't know, even, okay, if you don't know what can be asked, so prepare your topics in a way that you are knowing what are the things to do, what are the goals, what are the objectives. Okay, so thank you very much. Tomorrow I will try to have another unit, because actually in few weeks time there is some exam going on. All of you are welcome to ask anything anytime. And again, as I mentioned a number of times, that in YouTube channel, which is, again, I mention again and again that it's not a monetized channel, you will find all the topics. I have discussed all these topics so many times. Okay, and like neuro, you can find this playlist on neuro. Majority of the topics I have discussed in English. Some of them are in our native language, so pardon me for that. But you can review about it. There are certain neurological diseases like Parkinson's disease, epilepsy. Okay, and what else is new left in VP shunt? This is the question which they can ask with reference to hydrocephalus, especially in babies. So they can ask you this question about VP shunt. And actually, it's a very painful procedure when they try to put the shunt, when they are creating the room, and when they are putting it inside, there is a rod which they pass through it to create a hole. That's a very painful process. Okay. So rest, pituitary, acromegaly is a very important topic. So that's it, my dear. All of you, thanks for joining. So tomorrow we will be doing, what is MS? Multiple sclerosis. We are talking about multiple sclerosis, Anita. Okay. Okay, everybody, thanks a lot. And any questions, anytime, you all are welcome. I will just finish it here. You can note down my number. Anyone wants to contact me, you are welcome to drop a message on WhatsApp anytime. Okay. So you can just note down my number. And this YouTube channel, you will find all almost sorry. Who is this? Oh, okay, okay. I think this is coming from the video. I was literally listening from where this sound is coming. It was coming to me. Name books for MCI exam. Dr. Humera just messaged me in person. This is not a topic of discussion at this moment. And for you, you are not required. There is no advantage of doing MCAI exam. I told you many times. I'm telling you openly again. For you, it is only there is no choice other than FCPS. You should try to do FCPS. If you are trying to go to UK or Ireland, you should do PLAB. No need for doing MCI. Okay. Thank you very much and bye bye. Inshallah, we will try to have another unit like this tomorrow. Assalamu alaikum.